This is the Emergency Medical Minute. The Emergency Medical Minute is excited to announce that we are now offering AMA, PRA, Category 1 credits via online course modules. To access these and for more information, visit our website at www.emergencymedicalminute.com/CME-courses, or simply click on the link in our show notes and create an account.
So we're going to talk a little bit about evaluation of this specific rash and the implications that it has in terms of making the proper diagnosis and avoiding complications thereof. So basically this is a case of a 7-year-old that came in, no real contributory past medical history in terms of past medical history, maybe some exposures that we can talk about when we talk about the case in more detail, but no real contributory past medical history, who developed a rash that initially started on the trunk and then went to the extremities over several days. He's never had a rash like this before. He's otherwise been doing well, no fever, tolerating orals, and no other systemic symptoms. So as far as sort of a framework, rash is something that we see commonly in the ER, pediatric rashes being somewhat more common in general. In terms of organizing ourselves with regards to a differential diagnosis of a rash, some of the things, some of the schema that we would think about as providers is, one, is it sort of a life-threatening rash? Is it something that's potentially dangerous? 2, does it represent sort of a classic rash? And then 3, if you're really sort of stuck, you organize it sort of by the anatomic distribution and the features of it. What are some of the terms you've heard used to describe a rash? What? Raised, okay, so generally a raised rash that's less than a centimeter is called a papule, and if it's greater than a centimeter, it's called a plaque. Flat rashes are called macules. Oftentimes people use the term maculopapular if it's, has features of both. Vesicles are fluid-filled, generally less than half a centimeter. Bullae are larger blisters, greater than a half centimeter. Petechiae, sometimes you've heard of, so those are non-blanching, sort of pinpoint lesions. Purpura is, either a flat or raised purplish lesion. So how would, if you were describing this rash here, you'd say it's probably macular, maybe maculopapular. What kind of characteristic features does it have? Because this represents both a classic diagnosis and also a diagnosis that in its extreme form can be potentially life-threatening. So how would you describe that rash other than macular?
It's a little purple.
So purplish, yeah, And then how about the shape? Circular, yeah. And then, what's that? Nice. And then one of the things that should sort of come to mind is that this represents like a target. Does everyone see that? So generally, the central area of this classic rash is red, target, and then a ring lighter, and then sometimes an outer ring beyond that, that's sort of pinkish. So target-like rash, is that something that sort of triggers some specific diagnosis for you?
Lyme.
Lyme, yeah. So this isn't Lyme, but Lyme can give that. Lyme disease gives you generally a single expanding target lesion. Centrally it's clear, and then the redness is on the outside. But that is a classic lesion. It's called Erythema chronicum migrans. So this is something different. Thoughts? So this is called Erythema multiforme. You guys ever hear that term? So you will when I put it in the context. So this type of hypersensitivity reaction is Erythema multiforme minor, Erythema multiforme major, Stevens-Johnson syndrome, right? So I see a lot of nodding there. And extreme, it's called Toxic Epidermal Necrolysis, TEN. Stevens-Johnson is sort of what we would sort of be most worried about, because those patients, that's sort of in the progression of this to become something potentially life-threatening. In terms of causes, Stephen Johnson or TEN or erythema multiforme, are there any things like that you think of that are characteristically associated with those conditions? Aspirin, right? So aspirin, NSAIDs, so drugs are common triggers. So the big categories there are NSAIDs, including aspirin, antiemetics, classically phenergan, anticonvulsants, phenobarbital, which we're using more frequently, or dilantin, and then importantly antibiotics, penicillin and sulfa. The other big category of triggers is viral infection. So in kids, 50 to 70% of patients who have erythema multiforme have HSV infection or mycoplasma pneumonia, which was the trigger for this patient here. In terms of the importance, it's generally just providing reassurance and supportive care, removing the offending agent. If it does progress to involve mucous membranes, it's called erythema multiforme major. If it has extensive involvement, but still less than 10% of the skin involved, it's called Stevens-Johnson syndrome. And once that happens, where do those patients go? Do you know? So they go to burn, yeah. But here they would go generally burn ICU. And if it's TEN, it's greater than 30%. So basically, this is just sort of a classic pattern rash. Hopefully, it gives you a little bit of context on how we think about rashes in general, including a classic and potentially very dangerous rash. And the intervention is basically remove the offending agent, treat supportively, and monitor for progression to things like Stevens-Johnson syndrome or TEN. All right?
Thanks.
Yeah.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.